Good evening, everyone. Thank you for joining us for tonight's discussion on the management of metastatic lung cancer with the use of immunotherapy as the backbone of this therapy. There's a lot to talk about, and we're fortunate to have Dr. Edward Garon from UCLA, professor of medicine and lung cancer specialist, to join us along with our moderator, Dr. Hatim Husain. I want to thank everyone for being here, and in particular, I want to thank our sponsors, AstraZeneca and G1 Therapeutics, for help supporting tonight's meeting. So without further ado, I'm going to transfer the baton to Dr. Hossein, and we'll go from there.
Thank you, Dr. Lashkari, and it really is a great pleasure to be here and have a good discussion with Dr. Garon and yourself actually about the first-line management of non-small cell lung cancer from an oncogene wild-type perspective. And I'm going to share some slides now that I've prepared here. Seconds. So we're going to, do a little bit of a deep dive, Dr. Garon, on the first line management of non-small cell lung cancer. And obviously this is a complex space, but I think certain principles that would be great to talk about are, firstly, we have several different approvals and regimens that are available to patients in the first line. And now we think about, the right regimens for patients in different ways. So I'll first start with some slides, and then at different points, it'll be great to kind of, pause and Dr. Lashkari and Dr. Garon, it'd be great to kind of, talk a little bit about our practices, and also, Dr. Lashkari, from your practice, as well
Absolutely.
as from Dr. Garon's practice, really kind of seeing trials and tribulations, points of interface, and how, we think about, these things collectively for patients. So one slide actually that I adapted from a slide of Justin Gaynor is actually this slide. He did a really good job of breaking down some of the therapeutic strategies as it pertains to first-line lung cancer. Here represented are both non-squamous and squamous. Really a key component is next-generation sequencing testing, molecular testing, to identify oncogenic drivers. Really kind of his thought process and strategy was, if a patient does not have one of the drivers noted, really relying on PD-L1 to make that decision. Here listed are some of the regimens that he had depicted across each PD-L1 level. And I think this is an interesting way. It actually really kind of dissects down how molecular testing really sets the stage. And I will actually turn to you, Dr. Garon, in this point and say that, in your practice, do you view molecular testing as kind of the initial milestone? And are there circumstances or considerations or kind of patients in whom you feel like starting without a molecular test result? Like, how do you view that, and how do you think through kind of that, that situation for patients?
Yeah, so I really do view the molecular testing as the first step. Now, the setup that we've set up is that we do have a result that comes back very quickly for EGFR and ALK, and that helps us a lot, because oftentimes we do need to wait a couple of weeks, for instance, for a full panel of molecular testing. That on occasion can be of concern. I think that that most patients, it's fine to wait a couple of weeks, but there are some patients where we feel pushed. In general, in those cases, I really have tended to withhold the immunotherapy in the first cycle to determine whether or not we have evidence of a driver mutation. I think, like any decision in medicine, there are times when that we sort of say that this is the way it should be done, and maybe don't. So for instance, I can imagine somebody with 120 pack-year smoking history. I'm worried about whether the biopsy is going to give me a result. I already have a result for EGFR and ALK. I think those are situations where I often do feel comfortable starting down this pathway, assuming that it is unlikely that a driver mutation that sort of changes my approach will be found. But in the great majority of patients, I think we have time, and we should certainly be waiting for these results prior to starting therapy. And in most of the cases in which we don't feel like we have time, I've generally withheld the immunotherapy in cycle 1.
Thank you, Dr. Garon. Actually, and I'll say kind of my practice reflects that too. Dr. Lashkari, I'll maybe turn to you and say, in a community practice setting, and if you think about kind of your lung cancer patients, are there circumstances where you've had to go forward or went forward without kind of having the molecular test? Like, are there circumstances and perhaps kind of logistical issues or issues that kind of make it really difficult to have all the data up front?
That's an excellent question, and it is something that we deal with on a regular basis. I will say that, like Dr. Garon mentioned, I think it's important to have the molecular testing back, but if there is an opportunity to wait for it, if the patient is not in any clinical crisis, then I think it's very reasonable to wait until we have that information back. And, I think, like most of, you and our colleagues are now incorporating both liquid and tissue NGS to help provide some the framework for this. In the event that we don't have this information back, I generally will initiate systemic chemotherapy without immunotherapy until we have the full panel back, only because we can see high PD-L1 levels and get excited about that, but then we'll see a targetable mutation, and that is so it's not as appropriate to start immunotherapy in a patient for whom a targeted therapy may be a candidate, especially if they have an EGFR or ALK mutation for which subsequent targeted therapy after immunotherapy may increase the risk of pneumonitis.
No, excellent points. And I think, it sounds like that practice of the chemotherapy, I've definitely kind of seen and been in circumstances, though, where if a patient has PD-L1 of 90%, and we're struggling and waiting for these results and perhaps kind of don't have the results, I could see how, there would be a push or a drive to get started with an IO or monotherapy. And so I do think that, there's case-based considerations here. Dr. And I may ask you, and under that circumstance, where, patient has 90% PD-L1, hard to get these molecular tests back. And, for whatever reason, let's just say it's not there. And maybe perhaps we got a message that the tissue is inadequate. Would you go forward with the immune therapy, or retest, like a new biopsy? Kind of, how would you think about that?
I think it's an excellent question, and I think that in the end we sort of take into account sort of like any medical decision we have, which is we try and weigh the risks and benefits. There are cases in this setting where I have gotten sort of circulating tumor DNA, which often will come back quickly. Presumably, you're describing a case where we have a pathologic diagnosis, so we know that it is non-small cell lung cancer, but don't have any molecular testing. I think that is, in my estimation, a very good use of molecular testing. If an EGFR mutation comes back, I feel very comfortable that patient is, that and the approvals would indicate that patient can just get directed therapy. Also, if I have a result that shows, for instance, other known oncogenes that are present at a respectable percentage overall, that I feel comfortable that it is unlikely that a driver oncogene is going to be present. I think the problem with that approach that can come up is the reason that again you have to sort of consider carefully, I think, in the rebiopsy. Let's say you wait a week for that result and then it comes back and there's nothing found. That doesn't really increase your likelihood substantially that that patient does not have a driver oncogene. And I think that's the difficult thing. But I think that this is one where I really do defer to sort of people in their local practices. If it's going to take you 3 weeks to set up a new biopsy and your provider for molecular testing is going to take another 3 weeks, we're talking about a long time. And that does start to get certainly into an area where we don't feel comfortable. So I think that it's one of those situations that I don't know, Dr. Husain, if you view it differently, but it's one of those where I sometimes see my house staff sort of criticizing what's happening sort of at the outside. And I think often maybe perhaps unfairly. I think it does depend on your circumstances. And if a rebiopsy is going to take several weeks, and interpretation is, I think it does become quite hard to wait that period of time. Does your practice different than that?
No, I think that's such an astute observation. And I will also say I've heard another person comment that the medical oncologist is in perhaps kind of the most unfavorable position because, obviously we're not in control of being able to get those results as timely as we want them. And not being in control of the scenario and actually, having to make some of these tough decisions, put medical oncologist a little bit in a vulnerable position or a kind of uneasy position, in being able to do that. So definitely empathize, and also want to say, I mean, if this is a real issue, and I think perhaps maybe it affects academic centers, it affects community practices. And I think that maybe the take-home message here, and the best message that can be imparted, is, really kind of doing what's within one's capacity to be the best stewards, to get the results, act on the results, and be timely as it pertains to that individual in front of the patient. And I think what that also means is, really kind of thinking a little bit about how to sequence, Dr. Garon, you mentioned kind of chemotherapy alone, and kind of in circumstances actually where, really also using some clinical factors as well as molecular factors to really drive the decision. I think these are all really key important points. So yeah, no, I think, it's a little from like, say, a house staff perspective, or kind of a perspective that isn't directly, kind of interplaying and kind of looking onto the process. It is a process actually where, unfortunately the medical oncologist can't always control the timeline, but I think having the diligence, being aware, and also making informed decisions about how to act in the best interest of the patient with the constraints that exist, I think are always kind of the best ways, that one can think about there. So I think kind of with one thing, and this is actually going into some of that discussion, is that we know that, lung cancer is a very diverse disease. There's many different oncogenes, and depending on the specific oncogene that exists, there may be differential response with an IO. And actually, as your group has very elegantly described, and both yourself and Dr. Lisberg, have, really demonstrated the importance of having the molecular test, or acting in the best interest of the patient for their first line as it pertains to a targeted therapy in EGFR, specifically in this context where your trial actually really provided a great glimpse to the world about the value of testing to find, these actionable mutations, realizing that IO, even in high PD-L1 patients, has a low response rate, and actually the sequence of, an IO and then sequential targeted therapy with an EGFR therapy can have toxicity with pneumonitis and hepatitis. I've always been so enamored by that trial because, to be honest, the N on that trial was, was limited, but it provided such important information with that subset, and really kind of, it was enough to drive home the point and really inform practice quite broadly based on that trial. So yeah, no, actually, I think, the contribution that your group has provided the field in that regard is truly amazing. So yeah, no, thank
Very
you.
nice, thank you. I always, when I talk to trainees, I always say that it's great to have your hypothesis be confirmed, but if your hypothesis ends up being so bad that you sort of roundly refute it, that's still a value. What really you don't want to get to at the end of a study is that you see the study results and you're not sure what it means. And unfortunately, we're pretty sure at the end what that means, which is that our hypothesis was wrong and that these patients should certainly get targeted therapy prior to immunotherapy, certainly at least with the EGFR. And I think that with ALK, it's certainly true. I think it becomes more difficult, frankly, with some of these others. I think that when you start to get into BRAF, MET, I think the data is less clear. I don't know if you've viewed it the same.
So, it's interesting, actually, we're doing a retrospective analysis on our patients actually who have gotten IO for V600E. And we have, some elements of a cohort where some patients actually have gotten just IO-based therapies, maybe, kind of didn't go forward. And how did those patients do versus if they didn't get an IO, and such. So I think the field is complex, and I don't know that we have a very concrete answer, but I do think this is V600E patients have lower tumor mutation burdens. They may have smoking associated, and I recently, looked this up to kind of say about, in the trials, and there was recently a trial actually presented at ASCO with encorafenib and banimetinib, where about 60% of patients who are BRAF V600E mutant smoking histories. But the diversity in BRAF is one where the non-V600E seems to have more smoking affiliation and higher tumor mutation burdens. So I think there's a lot of heterogeneity here. And the question came up about, for a BRAF V600E patient, would you proceed, who is high PD-L1, like let's just say 80% PD-L1, would you go with an immune therapy strategy, or would you go with BRAF MEK strategy? And I may ask you that question, Dr. Garon. Actually, what would you do in that circumstance? Actually, high PD-L1, 80%. Would you go with immune therapy there, or would you go with the BRAF MEK for that patient?
I would go with chemoimmunotherapy in that setting. I think in these driver mutations, I've been a little nervous about single agent immunotherapy, but there are clearly patients who derive significant benefit from immunotherapy. The other thing that's a little bit hard, and the regimen that you mentioned, which is not an approved regimen, is a little bit better tolerated. The approved regimen is no walk in the park, and I think that this is often a sort of a trap we get ourselves into, and I'm interested in Dr. Lashkari's opinion on this because sometimes we sort of evaluate that, oh, this is a targeted therapy, so it's going to be better tolerated, and some of these combinations for BRAF, I have not found to be particularly well tolerated. I found that sometimes chemotherapy may be better tolerated, and that may not come out in a study because hematologic toxicities are so outweighed in clinical trials. But I don't know, Dr. Lashkari, have you had any experience sort of similar to the things that lead to my concern?
Absolutely, no, absolutely. I think that oftentimes the benefits of the thing about chemotherapy is that the side effects are often very predictable, whereas with targeted therapies, they may be difficult to predict. A lot of patients may have unique side effects or side effects that may not be as easily managed with dose reductions or even delays in therapy. And certainly, I've had issues with patients across all the different targeted therapies, for whether it's for MET, HER2, ALK, BRAF, certainly, both in lung cancer and in other cancers like melanoma. These drugs can be challenging to use, and oftentimes in the community, what happens is that we may not see, like, for example, how many patients are we treating with, meta exon 14 skipping deletions or with RET and ROS? It's not a lot. So, when we are using these drugs, it requires us to, try to get quite familiar and read up on the side effects and follow the patients closely, because, the side effects can be a little bit, not as predictable. So I think from that standpoint, it offers some challenges. But that being the case, I think overall these targeted therapies, certainly with their frontline use, have significant benefits. And so, I mean, that's why we use them as initial therapy. But in regards to side effects, yeah, the profile can often be a little bit more predictable using chemotherapy.
I also like to remind my house staff that anthracyclines have a known targets topoisomerase 2, but what makes something a targeted therapy or not, I guess is a little, I don't think we would list that as the poster child for targeted therapies. And so not that the combined BRAF and MEK inhibition has that sort of tolerability issue, but to that extent, but it's not always so clear, I think.
Yeah, no, thank you. Actually, wonderful discussion. Actually, Dr. Lashkari, I may ask you that very same question that I asked Dr. Garon as well then. So BRAF V600E patient, first line, would you do dabrafenib and trametinib? The patient has high PD-L1 or chemo IO. Which one would you do?
I think I would initiate targeted therapy as initial therapy. Knowing that the response rates are high, and I don't know if there's no head-to-head data, but that would be my initial bias. Yeah.
Super interesting, and really shows a gap where further studies and better analysis here to really understand. I know in melanoma, this question has been raised and that actually has been answered, where first line actually they showed that starting with IO, exactly, IO combination, was superior to starting with the BRAF approach for the BRAF V600E melanoma patients. So very curious. Also looked up, actually, by the way, because I was reviewing this, actually, that there've been studies of BRAF MEK plus IO in melanoma and colon cancer. But we only have one trial in lung, which is ongoing now. So we'll have to see how that unfolds. So with that,
the other thing I was just going to point out that I think is a little interesting is that it also matters where one practices. So, for instance, I was very involved in the original study of capmatinib for MET exon 14 skipping, and in the United States, there's an approval that is line agnostic. But in Europe, the approval is specifically for second-line patients, and the regulators basically said that the data was insufficient to say that in a non-randomized setting that this would be a better therapy as opposed to chemotherapy. So there's significant regional variation in this.
Super interesting.
Well, and also for these drugs that we're referring, that these studies in regards to the targeted therapies, usually these approvals are based on phase 1 or 2 single arm trials, and they're not necessarily randomized. So it doesn't, provide a lot of information from a comparative standpoint.
I think super interesting, and thank you for driving some of these points home about just the importance of molecular testing and how to proceed there. What I've done here is that I have a slide which lists out many frontline trials, mature trials, and in fact, actually those trials that have led to FDA approvals. This is not the whole list, but many of them represented here. And what I'd like to do is to kind of speak a little bit about some of these trials specifically. And, obviously, one of the biggest questions right now in the first line lung cancer space is which patients actually are the right patients for a CTLA-4 based approach, a VEGF based approach, in addition to, the PD-1. So I'm just going to review some of this. Wanted to start by showing some of the safety profiles for the ones that I've shown. I think some key points over here are looking at the treatment discontinuation rate. And we can see that, there are, treatment discontinuation rates that can, we would think actually that perhaps dual IO may have higher discontinuation rates than, the original PD-1 plus chemo trials. It's kind of curious, though, when you actually look at the details, that the treatment discontinuation rate seems a little bit more comparable under those circumstances. The grade 3 or higher AEs is, generally higher in, it looks like dual combination. However, there is heterogeneity across each of the trials here. So Keynote 189, really kind of a major way in which we practice, has set, a lot of standards in first-line management of non-small cell lung cancer, specifically non-squamous non-small cell lung cancer. Here's a hazard ratio of 0.49. Subgroup analysis, really kind of having benefit across the subgroups that were looked at over here. Keynote 407, also a trial that showed very clear hazard ratio with overall survival across the multiple subgroups looked at too. Empower Lung 3. So this was a study actually that looks at samiplomab, another PD-1 inhibitor, plus chemo versus chemotherapy alone. The medicine samiplomab is continued every 3 weeks until 108 weeks. Again, 4 cycles of a platinum doublet chemo. Here shows overall survival as well as PFS. We can see a significant benefit with the addition of the samiplomab PD-1 to chemotherapy versus chemotherapy alone. And then subgroup analysis looking across PD-L1 strata. You can see this over here. And then, so actually, Dr. Garon, I may just take a pause and just say, what is your view on samiplomab? And do you see a space for it and certain populations or kind of certain circumstances where, may be appropriate for
Sure.
considering your practice? Mm-hmm.
So my view on samiplomab is that that there is sufficient data at this point to say that you can feel pretty comfortable that this is a comparable drug to pembrolizumab, for instance, in the chemo immunotherapy setting and in monotherapy. The one thing that I find harder in struggling with is when I'm very familiar with pembrolizumab and when my patients are familiar with it and watch the advertisements for it during the football games, it's been a little hard to sort of push for it because I don't necessarily see anything to date that's either better nor worse in the data that we've had to date. So the way that I view it is that it generally has not been something that I've adopted as my standard approach. On the other hand, I have no concerns if I were to have a clinical trial where it was considered the backbone PD-1 inhibitor. And someone told me, for instance, that I have to give that rather than pembrolizumab for in those settings, I wouldn't necessarily fight back because I don't think the data really would support a significant difference between the two.
Thank you so much for sharing that perspective. Dr. Lashkari, your view on this? I think you're on mute, actually. Sorry.
I have not used samiplomab in the treatment of lung cancer, non-small cell lung cancer. I have reviewed this data not long ago, and like Dr. Garon said, I'm not certain what there is that might make this a more attractive option compared to, for example, pembrolizumab. I can only think of one strategy that could make it favorable for a practice to transition to this approach, and that's if there is some, if it's favorable from a financial standpoint, in the sense that the drug is easier to purchase, for example, from a cost standpoint. But I mean, beyond that, I don't see any clear benefit beyond what we're already seeing.
No, thank you for sharing that. And I think that the point of not necessarily having concern, about its use, or kind of if patients are eligible. And Dr. Garon had made the point that people do follow their familiarity, in some regard with the medicines that are being used. One aspect of the Empower Lung 3 study that, or I'm sorry, the Empower Lung 1 study, which was greater than 50% population, is that they do allow at progression the continuation of a PD-1 with the addition of chemotherapy. And that, that is a part of the trial that, seemed unique from some of the other studies. And so, that data has been particularly interesting to kind of also reflect upon. And Dr. Garon, actually, just speaking to that point, in your practice, if you have a patient who is on, let's just say monotherapy, greater than 50% PD-L1, and they progress, what is your practice about the continuation of a PD-1? Do you do that? Do you see, kind of how do you view that? And let's just say across the PD-L1 strata.
So this was sort of a funny thing because, I'm involved in some international studies, and I was in one second-line study, and I wanted to sort of allow for this approach. And my colleagues in Europe, where they have socialized medicine, where it's more prescribed, they thought it was crazy that anybody would do that, because there are no approvals for that approach, and frankly, very little data. You mentioned the Empower study, which had some data, but unfortunately was added a little bit late in the overall conduct of the study, so that the numbers were not particularly robust. I do find that I do it with some frequency, and I don't know that I have great confidence that it's helpful. I think that this is one of those difficult situations where patients really sort of get excited about the idea of immunotherapy. They like it conceptually. On some level, it's their own body fighting against the tumor with the sort of a substance that's helping their immune system fight against the tumor. And so also they recognize that there have been substantial benefits, including long-term benefits. I think patients are very reluctant to give up that thought. And so it is something that I've done on some frequency. If you asked me, how confident was I that a study that randomized to chemo alone versus chemo plus a PD-1 or PD-L1 inhibitor at that point would show that it's better to continue the PD-1 inhibitor, I would say that my level of confidence is very low.
No, thank you. Yeah, no, I think this is great insights, for all of us here. So with that, actually, I think we're going to move into this topic about the role of CTLA-4. And again, just reviewing some concepts. Checkmate 227 looked at nivolumab plus ipilimumab. Basically, there's an FDA approval for this strategy for the PD-L1 greater than or equal to 1%. There was an analysis done for the less than 1% as well. Here we see 5-year overall survival for each of those categories of PD-L1 greater than or equal to 1%, where we see at 5 years with dual IO, 24% of people alive versus nivolumab alone, 17%, and then chemotherapy, 14%. For the PD-L1 negative patients, at 5 years, 19% alive with the nivolumab plus ipilimumab, nivolumab plus chemotherapy, 10%, and 7% for patients actually with chemotherapy. This brings us to Checkmate 9LA. So this study actually looked at 2 cycles of chemotherapy with ipi-nivo versus 4 cycles of chemotherapy. Treatment was given until disease progression, unacceptable toxicity, or for 2 years. Primary endpoint was overall survival, secondary endpoint, PFS and ORR, and the efficacy by PD-L1. Here is the overall survival and the intent to treat patients at 2 years. We can see 15.8 median overall survival versus 11 months in chemotherapy alone, hazard ratio 0.72. And here's a subgroup analysis across histology, PD-L1 score, as well as CNS metastases. Here we can see that at 3 years, the 9LA regimen, 25% survival versus 15% with chemotherapy, hazard ratio 0.67. And that was, for the PD-L1 negative. So now let's also kind of review that there is data in brain metastasis in this circumstance, 0.43 hazard ratio. And, we can see that in patients who develop new brain lesions, it was less on the nivolumab plus ipilimumab plus chemo group versus the chemotherapy alone. So in the subgroup analysis in the brain, we can see that in patients actually who had CNS metastasis, hazard ratio 0.47, those who did not have brain metastases, 0.79. So I may just take a pause there, quick pause, and actually ask you, both Dr. Garon and Dr. Lashkari, in your practices, have you been using CTLA-4, let's just say kind of the 9LA regimen or 227? I'm also curious just about 227, and are there patients actually that you would use dual IO without the chemo? Or, with the chemo, how do you think through the addition of CTLA-4 for patients?
I'll make it easy. I have not adopted this regimen into my treatment course for my patients, mainly because I shouldn't say that. I have offered it and I've used it on a couple of occasions, but it's not something that I would consider as my go-to, mainly because I think that initially the long-term data wasn't clear to me whether or not this might provide some long-term benefit, which I think is one of the selling points of this treatment. Now that we have some long-term data, it appears that there are certainly a group of patients that benefit. And so I actually wanted to ask the both of you how you view this regimen, whether given alone or in combination with chemotherapy. Are there certain patients that you would use it for? I mean, the data would suggest that perhaps in those with the low or the PD-L1, less than 1, those patients might respond a little bit more favorably compared to not receiving it.
Yeah. No, I think that's super important. And I do think actually that some of the subgroups that have really been analyzed with a lot of scrutiny in this trial and in the next trial, Poseidon, that we'll look at, are those patients actually with PD-L1 negative, certain mutations, and we'll kind of go through that as well. Those patients with brain metastases. So I think, those are subsets. Actually, Dr. Garon, what is your view? Actually, have you integrated CTLA-4 and specific subgroups, or kind of how do you view which patients may be candidates for this and good candidates for this? Mm-hmm.
I feel similar to Dr. Lashkari in that it is something that I've discussed with patients on occasion have done, but is not part of my standard practice. And I think I can list a few things that have led me to some. So my big frustration in all honesty, and I've been part of some of these trials, including Poseidon, is there's a really simple question that we've never answered, despite randomizing probably 10,000 people plus to these frontline therapies. And that is, we've never definitively shown what the role of CTLA-4 inhibition is. And it's a frustration. There, of course, are study designs that would sort of clearly show this, and we've never used those. We've never tried to do that. So, for instance, you mentioned earlier that the discontinuation rate was even higher on, like, for instance, Keynote-189 than it was on some of these dual immunotherapy studies. But in some ways, there are a few things you have to remember on that. One, Keynote-189, for instance, treated people with pemetrexed forever, because that's what the approval for maintenance pemetrexed is. And so anybody who quit pemetrexed at any point would have discontinued the regimen. And so that's, you know, part of the issue. Also, there may be different patients that you would have offered a study to of a CTLA-4 inhibitor. So, for instance, an 88-year-old, you could imagine putting that person on Keynote-024, which was a single agent PD-1 inhibitor, but might not be willing to offer them Checkmate 9LA or Poseidon, which is going to be a 4-drug regimen, including a CTLA-4 inhibitor. Also, the only times we've ever seen comparison between, for instance, a 4-drug regimen and a 3-drug regimen, the PD-1 or PD-L1 inhibitor has not been approved along with chemotherapy. Those studies have been conducted and they just didn't hit their statistical endpoints. So I think that it's one of those things that if you're looking to make a case for it, you certainly can do it. If you're looking to say there's no strong data to incorporate CTLA-4 inhibitor, you can do that as well. And I think that's why you get such arguments among people as to what the appropriate thing is, because we really just don't have the data we need to make that decision. I don't know, Dr. Husain, if your view is different.
No, you know, I mean, I will say this is that I do think actually that speaking to your point about, you know, in an incomplete scenario, you know, we look at, you know, the data that's in front of us and how it applies for the particular, you know, patient in front. I will say in my practice, actually, for those patients actually who have, and we'll talk about this in the context of Poseidon, STK11 mutations, as well as PD-L1 negative, you know, tumor characteristics. These are patients that I do think and use dual IO when appropriate for patients. Maybe I'll take this opportunity to kind of show some of that data, because I do want to get your reflections and think about, you know, some of the fact actually where, you know, where you view the data here in a retrospective fashion. It is important to kind of say, how do we want to make our decisions? Are subgroup analyses and retrospective analysis sufficient? And I think if we are okay making, you know, those types of decisions based on that, you know, I think that, you know, obviously this is where, you know, the field is at for many of these issues. So maybe without further ado, I'll just jump into this really quickly and just show, here's the Poseidon study design. You know, basically phase 3 global study, first-line metastatic non-small cell lung cancer, looked at tremelimumab plus durvalumab plus chemotherapy for 4 cycles, and then actually the continuation of durvalumab, maintenance pemetrexed was allowed, and then there was one additional dose, a 5th dose of tremelimumab at week 16. So this is a finite dosing of CTLA-4 in comparison to Checkmate 9LA. I think another component is, as part of the Poseidon, there was an arm of durvalumab plus chemotherapy, and there was chemotherapy. The comparison that led to the FDA approval of Poseidon in this regimen with dual IO plus chemo was against the chemotherapy alone strategy. I think another kind of comparison against 9LA or versus 9LA is the fact that the treatment with the PD-1 was given until disease progression. And this is a point actually that is different than a limited, meaning a time-defined course of how long to give the PD-L1 or the PD-1 inhibitor in that way. So yeah, so finite dosing of CTLA-4 and also the doses of chemotherapy were different, 2 cycles versus 4. Here shows the PFS. Again, median PFS 6.2 months versus 4.8 months with chemotherapy, 12 months, 26.6%, progression-free versus 13.1, hazard ratio 0.72, overall survival 14 months with the Poseidon regimen versus 11.7 months with chemotherapy, hazard ratio 0.75. Here is the data for response. And we can see 39% with the dual IO plus chemo, 41.5 with the durvalumab plus chemo, and then 24% with chemotherapy alone. We can see the durations of response listed and those remaining in response across each of the subgroups in each of the cohorts listed over here. So here is a list of the adverse events on this. We had noted kind of the discontinuation rate of 15.5% in the dual IO plus chemotherapy arm. And that was compared to 9.9% with chemotherapy. So mutational analysis. So this has been an interesting area, and I'd love to get your viewpoint on this. So firstly, there's been recognized to be certain genes that may have less responsiveness to IO monotherapy. And STK11 is one. KRAS in certain circumstances is a heterogeneous group and, may have a more aggressive biology as well as KEAP1. Here is in the STK11 mutant subgroup, the PFS, with the dual IO plus chemo strategy on Poseidon versus chemotherapy. And we can see that PFS was 6.4 months versus 4.6. I really, think that the spider plots here can be illustrative just to kind of see the duration that patients are on therapy with response across each of these cohorts. You can see that the duration of response for the dual IO plus chemo was 13.6 months. When we look at chemotherapy, that duration of response just 3.3 months. Also, we can see the response rates over here, 45% versus 27%. At 3 years, we can see how the survival also is shown here, 25.8% alive at 3 years versus 4.5%. Here is the updated OS by STK11 mutation status. It was 15 months for Poseidon compared to 10.7 months with platinum-based chemotherapy. And, this is shown here for the STK11 mutant patients compared to the STK11 wild type patients. Here is the KRAS mutant patients. So the dual IO plus chemo showed a median PFS of 8.5 months versus 4.7 months with chemotherapy. Here is the spider plot. We can see response rate 55% with the dual IO plus chemo, 21.2% with chemotherapy alone, and the median duration of response 5.4 months and not reached with the dual IO plus chemo. And here shows the updated OS by KRAS mutation status, where updated OS was 25.7 months with the dual IO plus chemo, compared to Durva plus chemo, which was 12.6 months and 10.4 months with chemo. And if we look at the KRAS wild type patients, the dual IO plus chemo versus the chemo, is shown over here as well. So, just some summarizing points here, and I'd love to have discussion about this, is based on what's been presented across, and we spoke about PD-L1 score. We did speak a little bit about brain metastases, and we spoke about these specific oncogenes. Dr. Garon, in your view, do you view, how do you view the data as it sits in its sufficiency to inform your practice as it pertains to the first line and considerations for IO?
Yeah, I think that the one thing that I think is particularly interesting are these sort of negative prognostic markers, STK11, KEAP1. We know that outcomes generally have been less good across multiple different therapeutic approaches in some of these populations. And the data, I would say, is intriguing but not definitive. I think one way of looking at, for instance, STK11 mutation data from Poseidon, I think there were 65 people that were in either the dual IO or the single IO, and the dual IO had 7 people who were doing well at a year versus 5 in the single IO. So is that better? Yes. Does that convince me? In a subset analysis, not necessarily. We are looking forward to starting a study where we're actually going to look at these populations of patients and actually randomize them to this question. And I think that hopefully that will eventually answer it. And my estimation is really sort of the first time we'll ever design a study specifically to define the role of CTLA-4 inhibition really in any population in lung cancer. So I think that's going to be an important step.
Dr. Garon, can you can you describe this trial a little bit further?
Sure. So this trial would basically be randomized. So it's not open yet. But it will randomize people to the Poseidon regimen, the 4-drug regimen, including durvalumab and tremelimumab, and the KEYNOTE-189. Patients have to have either an STK11 mutation, KEAP1, and it looks like it'll also include KRAS mutant patients.
Yeah. And Dr. Lashkari, how do you view this as well? Actually, the data that I presented, do you feel like this data is sufficient enough to inform your practice if you have a patient in front of you who has an STK11 mutation?
Well, I mean, I think it's interesting that originally when we first started using immunotherapy, and we noted that there were some initial case reports and small cohort studies that showed that patients with STK mutations potentially did worse with immunotherapy, and that it would cause progression or like a hyperprogression of their cancer. But it is, as you've demonstrated, here, it's not clear that that's at all the case, and that we should not necessarily avoid, checkpoint therapies for these patients. I do think that this information is definitely thought-provoking and eye-opening, and so I think it's something to consider and think about. Whether or not I think we can hang our hat on it, I think it's still early to say, just because it's we're talking about small groups of patients and cohorts, but that's how I view it.
No, it's great to hear your perspectives. And I think there is. It's nice to kind of see how the field is moving in ways to really try to tailor these regimens to really find the right space for them. Obviously, really trying to follow from a scientific perspective the role of the oncogene, the role of these specific genomic events, how they influence the immune system. And I think really kind of probes our understanding on what additional both preclinical as well as clinical data do we need to help us understand how the genome, really can also be helpful for informing practice.
Absolutely, because with the dual checkpoint therapies, as the 9LA and the other BMS trial has demonstrated, that there is a tail to this curve. So it would really be nice to know, how we can identify those patients up front, because obviously the other concern regarding the use of these agents is the potential risk of grade 3, 4 checkpoint-induced toxicities.
So maybe just just a final question here. And Dr. Garon, I may ask you this point is in this quote unquote tailoring process in the first line, which patients do you see the best candidates to get a VEGF inhibitor in your practice? Which are the patients actually that you may consider for VEGF? Do you do that? And, how do you think about that class of medicine here?
Yeah, and I think this gets to the frustration we have. The one group that I have clearly used the EGF, the anti-angiogenics and the EGFR mutation positive patients. We now have an analysis of that population specifically. It did the population actually was EGFR ALK from the Empower 150 study, but nearly all of the patients had EGFR mutations, where they were randomized to chemo, chemo alone or the chemo plus the atezolizumab and bevacizumab, and it was clearly better to get the 4-drug regimen. There was another study recently out of China that really confirmed the same thing. So that is the one place I do use it. Outside of that, I've had trouble finding when to use it, and I think it underlies the frustration I continue to have. I think your description of tailoring is great, but we're being asked to tailor something when we've never really been told how to measure dimensions. And so, without that, it's really hard to know how to tailor. And so, it's sort of, trying to tailor without all of the data we need to do it has been a real frustration.
No, I completely agree with you. And I think that analogy of tailoring is complicated by the fact that if there are too many variables involved, then the attempt at tailoring is limited, just insofar as what you can control, and you can't really tailor, complex multidimensional systems as easily. And Dr. Lashkari, in your practice, actually, VEGF, do you do that in the first line?
Yeah. So no, I would say that I very much follow what Dr. Garon has mentioned, and that is, the data that we've seen with patients with EGFR mutated lung cancer in like second-line therapy with chemotherapy, they tend to do well, and that's typically where I use it. I have I have used the Empower regimen, the 4-drug regimen, in EGFR mutated patients as second-line therapy following osimertinib, and that's where I found it helpful. I know that there's some data combining bevacizumab with earlier generation EGFR inhibitors. I haven't really used that in my practice, but those are generally the patients I reserve it for. I'm not, using it too often as a backbone, for example, with immunotherapy as like a maintenance, for example.
Really interesting point. And actually, I was going to get to that in my practice, I will say that, I do integrate VEGF as a subsequent line, subsequent therapy, whether it's with docetaxel. And Dr. Garon, actually, your Rebel study is still holding up, and now almost a decade after its publication, as well as recent work actually with the SWOG data set, kind of looking at the lung map study, looking at pembrolizumab plus ramucirumab as well. So I think it's curious. In my practice, I will say that VEGF still has carved out a spot either in combination with chemotherapy or IO in subsequent line therapy. I also may consider it for those people who have brain metastases earlier as well, depending on how symptomatic those can be. So with that, actually, maybe I'll just take this opportunity, both Dr. Garon and Dr. Lashkari, to kind of say, if you guys have any last words based on what's been presented, anything that you think actually for ourselves in practice, perhaps things that you would reflect here, or kind of just comment as a parting advice for us.
Well, thank you for allowing me to participate in this discussion with you guys. I don't have much more to add. I'll leave it to you guys. You guys are the experts.
I will say,
No,
Dr. Lashkari, we learned from you.
Thank
I
you.
was going to say that's exactly true. And I think that the other thing that I was going to say is that on some level, I think it's hard from where we sit today to remember just how exciting it is to have these be the sorts of questions that we're addressing. That the fact that we are looking at some of these patients who are out on the tail of the curve, the fact that I do have patients now in my clinic who are 10 plus years out from
Amazing.
immunotherapy, and that although I'm listing a bunch of frustrations about, study data that I don't have that would help me in deciding how best to use these agents, I think it's easy to lose sight of sort of how far we've come.
Amazing points, actually. It's so, I think that is totally true. Actually, we have come a long way. And Dr. Borghaei has also, just joined. So Dr. Borghaei, thank you also for taking, the time to join us as well. And, Dr. Garon has just mentioned actually how far we've come. And thank you, Dr. Garon, as well as Dr. Borghaei, as well as all others who kind of really have paved the way for moving us into this space. And so really, I think it's great to see where we are.
Hello, everybody. I'm sorry I'm late,
Yeah.
but I'm glad to be here now. Thanks.
No, thank you, Dr. Borghaei. And while you're here, actually, I may just ask you, so we presented, a lot of data in the first line, dual IO, so CTLA-4, PD-1, and monotherapy. I may just ask you about your practice, actually, in the sense that are there specific patients that you prioritize in terms of CTLA-4, kind of thinking about those patients? How do you determine which patients and to get which approved therapy in the first line for non-small cell lung cancer oncogene wild type? I know it's a loaded question, broad question, but any reflections that you could provide us, particularly also about dual IO?
Yeah, thanks. I don't think it's a particularly loaded question anymore. This has been discussed, and I've been pretty honest by saying that I have a certain bias towards IO combinations in general. I would tell you that in my practice, PD-L1 negative tumors, particularly the squamous histology, I preferentially treat them with an IO combination. And again, the regimen that I have sort of adopted so far is the 9LA regimen with 2 cycles of chemo and ipi-nivo, and then continuing with the ipi-nivo as long as patients are tolerating and there is clinical benefit, obviously. I think the main reason for choosing 9LA is that I still think that 2 cycles of cytotoxic chemo helps in certain patients in terms of avoiding that rapid progression that sometimes we see in this disease. But I think that the so-called tail of the curve is a little bit better for the people that want negatives with an IO approach. So that has been my recent sort of practice in terms of what I do. For patients with high PD-L1 expression, I've been using single agent checkpoint inhibitor, and the 1 to 49%, I still think chemo IO is a reasonable combination given the data that we have now. I would also point out that now we have more retrospective and small database analysis of patients with STK11 or T1 mutation, suggesting that perhaps, particularly again in the case of T1 mutation, a CTLA-4 antibody can be helpful. That comes from a retrospective analysis of the 2 to 7 data, where there were something like less than 40 patients with T1 mutation, so the numbers are really, really low. And again, retrospective in nature. And then the more recent presentation by Dr. Solange Peters at World Lung Conference in Vienna, based on the analysis of the Poseidon study, began looking at several different subsets of patients, including KRAS mutation versus wild type, STK11, and KEAP1, again, suggesting based on retrospective data that maybe CTLA4 can play a role in the STK11 KEAP1 mutant patient population. So now that these have randomized studies, I think we need to sort of have a prospectively designed trial, try to figure out if there is any validity to at least the STK11 KEAP1. But that's basically my take on the current landscape.
No, really, really insightful comments. And I will say this is that we spoke a bit about STK11. It sounds like STK11 would sway you for the dual IO approach. I may ask, actually, how do you view KRAS? Do you, Dr. Peters presented KRAS population, KEAP1 population, and STK11 population in the Poseidon study. Do you view each of those equally in your mind in terms of the differential response of a dual IO approach, or do you segregate, kind of based on each of those subgroups?
I kind of believe that the KRAS mutation positive subgroup, particularly the G12C, have a really good clinical benefit from a chemo IO approach of not using an IO approach in that particular patient population. Now, there is a little bit of an overlap. I think I just finished saying PD-L1 negative tumors are preferentially even IO, and there's a little bit of overlap between KEAP1, STK11 mutations, and PD-L1 negatives. But KRAS and as an isolated mutation, I don't really think that I use or I would necessarily go for an IO combination.
No, super helpful. And then last point actually to ask about this dual approach here is Poseidon had finite dosing for the CTLA4, a total of 5 doses. Checkmate 9LA, ongoing CTLA4, until progression. How do you view that distinction across the regimens? Does any of that influence how you think about what to consider there for a dual IO approach?
Yeah, and again, in the absence of trials to sort of look at this question, I'm sort of left to make a decision based on, I guess, again, your personal interpretation of the data. So I think the role of sustained suppression of CTLA4 is undefined in the world of lung cancer. I'm not really sure I have a lot of data in like melanoma renal cell top of my head to say that sustained suppression of CTLA4 versus limited makes a difference in terms of the clinical benefit. I would say that I have sort of adopted the 9LA or 227 approach, and I would like to stick to the regimen that's investigated in that particular trial. So as much as possible, I try not to deviate from what the protocol has shown to me in the clinically efficacious dosing schedule. But if you're a believer in the Poseidon and have more experience with that, I think then you stick to that regimen and use the 5 doses of the genomic in that particular study. So again, until we have more data and some sort of a comparison, I don't think I can tell you much beyond what I have said in terms of my hesitation to use the CTLA4 inhibition at this point.
No, super helpful. And in the, we did speak a little bit about how each of our practices was informed by our familiarity with the strategy that we were thinking about. But thank you so much, Dr. Borghaei. Actually, I know that you did a heroic effort to, still join us in transit. So really appreciate you joining us, and looking forward to, seeing you at, at the meetings and such. But with that, actually, maybe we, if there's any other further questions, and Dr. Garon and Dr. Lashkari, any also kind of questions for Dr. Borghaei as well?
I think you asked a lot of the interesting questions that we were discussing earlier. So thank you, Dr. Borghaei, for doing so.
Yes, thank you.
Did I say something that was completely off the wall?
No, not at all. Not at all.
No,
Not
but
at all.
I think it is actually very important to hear the diversity of opinions. And I also think actually that really one common point was just each of us may be very familiar with the regimens that we have either used more commonly or kind of seen. And so I guess the question in the field will be how with additional regimens that come in, what is the threshold to try a different or something new? And how stringent or kind of what is that threshold going to look like? Does it have to really be wholly superior or not? And this also came up in the context of the samiplomab studies, the MPower studies as well. So I think there are some common themes here that as a field, I think that speaks to some of the heterogeneity of practice.
Well,
with that, actually, just
yeah. I was going to say maybe on that note we should conclude. I know that we've run a little bit late, and I want to be respectful to everyone's time. Thank you guys, everyone, for joining us. Dr. Hussein, obviously moderating an excellent discussion as always. You always bring in your A game. Same with you, Dr. Garon. Thank you so much for joining us. And Dr. Borghaei, thank you for getting off the plane and joining at the end of our discussion. Thank you guys so much. And this will conclude our program. Again, thank you to our sponsors, AstraZeneca and G1 Therapeutics. Thank you. Good night, everyone.
Good night.
Good night.